Okay. Welcome all the participants on board. I'm glad to see uh, a lot of perio postgraduates and including the non-perio postgraduates on board. Welcome all of you. So we begin with one of the very important, I hope my voice is very clear and the screen has been visible to all of you. I guess it is clear. Dr. Sahiti, is it clear to everyone?
Yes, sir.
Okay, thank you. Anyhow, we are representing from Zeus-Terra Dental Academy, and this is the I think last week most of you have missed out. We had a webinar on muscles of mastication, and I think this week we'll talk about a very small and a brief topic about pain pathways. Okay, so pain pathways is something which is I should say very important for endo, especially endo, and I think for perio also it has been asked multiple times, like about the details about the pain pathway. Okay, now pain pathway, but before that we'll try to know what exactly you understand by pain, and there are many students who always ask which definition of pain should we follow. So the definition of pain we follow is from Monims. So this is again important for all the departments, that the definition of pain has to be followed from Monims. So it is an unpleasant emotional experience usually initiated by a noxious stimuli and transmitted over a specialized neural network to the central nervous system where it is interpreted as such. So we will try to divide this and we will try to understand what exactly do you mean by pain. So now when we talk about pain, you know that pain is a sensory what do I say? It's a sensory system. That means when you have pain, it is the sensory nerves which carry the pain sensation to your central nervous system. This you all know very well. So when it is basically when it is pain, it is being a sensory. So you all should know. I guess you all know what do you mean by sensory. Sensory means afferent and motor means efferent. This is something very basic. Sensory means something which is carried from the extremities or from the peripherals towards the central nervous system, which carries the impulses, a stimuli, which could be pain, which could be temperature, which could be a crude touch, which could be a soft touch, which could be pressure, nociception, anything. So that is what is sensory, which is afferent, and something which the brain gives the command is something which is coming down from the brain towards the spinal cord and towards the action is what is called as a motor, which is called as the efferent. This is something very important for you to understand. Now, when we actually classify the sensory receptors, we classify into exteroreceptors and interoreceptors. So you also have to understand that exteroreceptors can be cutaneous, can be chemoreceptors, or could be a telereceptors, whereas your interoreceptors could be a visiroreceptors or a proprioceptors. I think as a dentist, you all know very well that proprioception is present in which part of the tooth or a periodontium. And you know the importance of proprioception, which is very, very important. Okay. So now all the pain receptors are free nerve endings. See, now you have to understand that free nerve endings is something where the nerve endings are totally free and they are not enclosed in a capsule. So there is no enclosure of any capsule. There is a free nerve ending, and a nerve ending that actually responds to a noxious stimuli can actually or a potentially produce a tissue damage. So you need to understand that a nerve ending that will actually respond to this stimuli, which could be a noxious stimuli, will actually produce a tissue damage, because you know the tissue damage in the body is there, including even in the inflammation. So body will respond by damaging something to itself to prevent a major damage. So that you have to understand. Okay. So there are three types of stimuli which excite the pain receptors. Now, when we talk about the three types of stimuli which excites the pain receptors, you have got a mechanical stimuli, you have got a thermal stimuli, or you have got a chemical stimuli. Now, before that, we'll talk about a slight information about a neuroanatomy. Now you all know very well that neurons are there, and you know that a neuron has got an axon, it has got its own nerve bundle or a nerve fiber, then it has got dendrites. So now you know that from one neuron to the other neuron, the connection is basically because there's a slight gap which is called as a synapse or a synaptic gap. So that synapse will actually continue the neurons or the nerve cells from one neuron or from the one nerve cell to the other nerve cell. Okay, so this is how you know that every nerve fiber or every neuron or the neuron cell body, or what we now initially every neuron has got a neuron cell body which has got small branches which are called as dendrites. Then it continues to be into an axon. Now it is the axon which you have to understand. Can you see the axon in the picture? You can see the axon is covered by a red colored sheet which is actually not continuous but has got a break in between. The breaks which you are seeing in the myelin sheet is called as the nodes of Reinberg. Now you have to understand that when these axons can be of two types, could be a myelinated sheet or a non-myelinated sheet. When there is a myelinated sheet, that means when there is a myelin sheet, I guess you all know that the myelin sheet is formed from which cells? It's the Schwann cells. Now these myelin sheets which are there, this myelin sheet is not a continuous sheet what you see, it breaks in between, which I said you as a nodes of Reinberg. That means when there is a conduction of impulse between a myelinated and a non-myelinated, the conduction is very rapid in a myelinated sheet. Why? Because the conduction jumps. You can see that the conduction will jump from one node to the other node to the other node. So when this type of conduction is called as a saltatory conduction. So whenever there is a conduction of the nerve from a myelinated sheet, the conduction is fast. When it is from a non-myelinated sheet, the conduction is slow. It is continuous, it is slow, but it doesn't jump. So these are the two types of nerve conduction. It could be a saltatory conduction or a non-saltatory conduction. Now, this is something very important as a dentist to all of you, that you have got the nerve fibers which are typically classified into type A, type B, and type C nerve fibers. You have got three types of nerve fibers. In type A fibers, you have got A alpha, beta, gamma, and delta. You have got type B fibers and type C fibers. Now, when you can see the picture of a different type of afferent axons here, you can see that type A fibers is the type A, B, A alpha, A beta, A gamma. All of them are myelinated. So you can see that they are all myelinated, and you can see the C fiber is non-myelinated. You can see the diameters and you can see the speed. So you can see that the speed is 80 to 120 meters per second, which is maximum in a thick diameter because it is myelinated A alpha fiber. Okay. This is a little explanation about when you talk about group A, group B, and group C. When you talk about group A fibers, group A nerve fibers, they are myelinated, largest myelinated nerve fibers. They carry all the sensations, somatic afferent. Afferent means sensory. When you see A delta, you know I'm pointing out A delta because A delta is concerned for pain. A delta is 2 to 5 micrometers. It is very, very narrow, and it carries I'm sorry, there are people trying to enter the webinar at this point of time. So, yeah. Okay. Okay. So we have got A alpha, we have got A beta, A delta. Now, as I am classifying into A alpha, A beta, and A delta is 2 to 5 micrometers. And A delta is something which is very, very important because A delta fibers are carrying pain and temperature, and their sensory receptors are free nerve endings or a thermoreceptors. So you need to understand that A delta is responsible for carrying pain and temperature. When you go to B, again it is myelinated. When you go to C, it is the thinnest, non-myelinated or unmyelinated. It is thinnest. So now you have to understand, when it becomes thin, that doesn't mean that it will work faster. When it becomes thin, that means there is no myelin. That means the action or the speed of carrying the sensation is little slow. It carries burning pain. It carries visceral somatic afferent pain, free nerve endings, nociceptors, very, very dull pain. So you need to understand, and I hope everyone is very clear that whenever there is a pain nerve endings, or pain receptors are free nerve endings. They don't have any sort of receptors. They are free nerve endings. They are basically A delta and C. But you have to understand the difference between A delta and C. So when you understand the difference between A delta and C, you have to be very clear that C is non-myelinated, A delta is myelinated, but very, very thin myelinated. Still, the axon is roughened because they are mild nodes of Ranver. That means the speed with which it carries the impulses of pain is faster when compared to C fibers. Okay. So now there was a Professor Field who has given that you have got a neural pain pathway. The neural pain pathway says that whenever there is a noxious stimuli, a stimuli which causes a pain, which happens basically by transduction. So you have got something called as transduction, where a noxious stimuli leads to an electrical activity, which basically, now what is an electrical activity? When I'm talking about electrical activity, maybe you have to remember your first year BDS physiology. When we talk about electrical activity, it is trying to talk about depolarization. You remember action potential? I guess everyone remembers action potential. You remember depolarization, repolarization, best. So now what happens, that there is an electrical activity which happens, then there is transmission, then the activity, then the impulse is carried towards the central nervous system, all along the neurons. Modulation, that nociception are changed or altered before it reaches the cortex, and perception, that interaction of the cortex, thalamus, and the higher centers. Now you have to understand one thing. You know that pain is carried from your peripherals by a free nerve endings. But where is the pain impulse going and getting processed? Okay. So which part of the brain is actually responsible for having a pain center? So you need to understand that there is something called as a somatosensory cortex. You have to understand that. Now, this is a very clear picture. Try to understand. This is a little difficult topic to get into so easily. Now, you have to know that whenever we are talking about sensory neurons, you have got three types of neurons: first order, second order, and third order neurons. Now, when we have so many types of neurons, you have to also make it very, very, very sure that these types of neurons which are present, when the neurons are there, the neurons are when I talk about first order neurons are carrying the sensation from the free nerve endings to the spinal cord. That means the peripheral system, it is carrying to the spinal cord. If you understand what a spinal cord cross section, you know that spinal cord has got a gray matter and a white matter. In the gray matter, you have got a dorsal horn and a ventral horn. So now you can you see the blue colored for primary neurons, the first order neurons? The primary neurons which are carrying pain, temperature, or coarse touch or a fine touch are primarily entering into the dorsal horn of the spinal cord, and there they are getting synapse. That means the first order neurons are getting stopped there and they are getting synapse. Now in that you can also see that there is first order neurons which is directly going towards brainstem, and one more first order neuron is directly getting synapse in the spinal cord gray matter itself. Now, from the first order neurons, these first order neurons, then they are second order neurons. Second order neurons are the red colored indicated neurons there in the picture. You can see that when there is a synapse in the spinal cord, the second order neurons get crisscrossed. That means from the left side, they go to the right side, and then they travel all along the brainstem. Now you can see that your brain, you can see a marking there. You can see a blue color at the top of the brain. Can you see a blue color, slight blue color shade where number 4 is written? That is basically the somatosensory cortex, where you have the location. Means pain from face, pain from head, pain from feet, pain from legs, hand, everything has got a center there. That is a somatosensory cortex. You can see thalamus, you can see medulla, and the whole brainstem. So these are the important structures what you can see. Okay, so now you know that brainstem, you have got medulla, about that you have got pons, medulla, everything is there in the structure, and this is all forming in the center line of the pain pathway. And the center 2, what you can see is the thalamus, where number 3 is written there. Okay, now you have to understand that the second order neurons are carrying the pain synthesis from the first order with the synapse and then going up, traveling all along Now, you have to understand at this point of time something very important. When the neurons are traveling towards the brain, the neurons are called as the ascending neurons. Please understand. These are the ascending neurons. What you can see in the blue, the red, and the black are the ascending neurons. When the brain sends down, it is called as the descending neurons. So these are the important terminology. So most of your afferent sensories are ascending neurons. Now, when they are traveling, ascending neurons from the spinal cord, from the brain stem towards the thalamus, from there towards the somatosensory cortex. Now, you have to understand that the pain is traveled, the impulses are traveling from the primary to the secondary order neurons or a second order neurons. From the second order neurons, they are going towards to thalamus. Thalamus is called as a relay station. This is very important question. Thalamus is a relay station. In thalamus, these fibers get a synaptic with the third order neurons. From thalamus, it goes towards the sensory. And you have to understand, if you have pain in the right side of your tooth, the pain fibers are carried towards the left side of your brain. You can see that the red colored neurons, you can see that there is a cross. The left goes towards the right, and then it travels all along. So you have to understand that there is a contralateral pain centers when we talk about these type of pain fibers, and these pain fibers are a fast pain fibers. These are basically neospinothalamic fibers. I will show you what exactly are neospinothalamic and paleospinothalamic. Now, the primary or the first order neurons carries the impulses to the CNS, the synapse to the second order neurons. Now, where do they synapse? The first order and second order synapse in the gray matter of the spinal cord. Maybe not in detail, but you should understand that there are various laminas in the gray matter. You've got lamina 1, lamina 2, lamina 3, like that. So they order. Now, when the synapse, when they have a, okay. Now, when there is a second order neuron, the second order neurons transfers the impulses to the higher centers. It's a transmissive neurons. And then you have got a third order neuron. Now, how will they send the transmission from first to second, second to third? So there comes the role of a neurotransmitter. So you have to understand that there is something called as a neurotransmitter, and we talk about two important neurotransmitters here. One is glutamic acid, and second one is substance P. And in the spinal cord, the area where there is the transmission or the synapse, that is called as substantia gelatinosa. Means that is an area where the synapse happens. This is the summary. This is the summary of the components of the pain pathway. That it from the receptors, it goes to spinal cord. From the spinal cord, it goes to medulla. From the medulla, it goes to thalamus. From the thalamus, it goes to cortex. Okay. So please understand that this is the way the fibers are traveling, and they are dividing into various neurons at the various synaptic junctions, and the components are all traveling with the help of a neurotransmitter, which sends the transmission from one primary neuron to the secondary neuron to the tertiary neurons. Okay. Now we come to the most important, the dual pain pathways. The pain pathways or the pain signals that take two pathways traveling to the brain. One is called as a neospinothalamic tract. The other one is called as a paleospinothalamic tract. Now, when we talk about a neospinothalamic tract, it is basically for fast pain. So when I talk about fast pain, I have already mentioned you in the before slides that there are two fibers which carry for pain, A delta and C. Among A delta and C, it is the A delta which carries the fast pain, because A delta is a myelinated thin fiber which transmits a mechanical or a thermal pain. And the neurotransmitter is the glutamic acid, glutamate, and it terminates in the lamina 1. It terminates into lamina 1. Lamina 1 means where? Spinal cord. Please understand that. Lamina 1 means spinal cord. So lamina 1 is a spinal cord junction of the dorsal horn, and which will excite the second order neurons. Okay. So that which will excite the second order neurons. So now neospinothalamic, try to understand when I'm telling you, from the pain fibers which are traveling to the dorsal horn of the spinal cord. From there, it is transmitted to the second order neurons, because it's the fast neuron, and it crisscrosses. Can you imagine the first figure which I showed you, blue and red? The red was crossing the spinal cord. From the left, it went to the right, which happens because of the glutamic acid neurotransmitter, which is sending the impulse from the primary to the secondary. And there, the junction is at a laminate 1 or a lamina 1 of the dorsal horn. Dorsal horn means gray matter. Gray matter means I'm talking about spinal cord. From there, the secondary order neurons goes. So now you have to understand that few fibers will terminate. So now when it is traveling all along to the thalamus, towards the thalamus, it gives something called as the reticular areas. Then they travel in thalamus. From the thalamus, it enters into the somatosensory cortex. So from starts the pain from the left, crosses in the spinal cord itself towards the right. From the right, goes straight along the brainstem, goes going towards the thalamus. It gives something called as the reticular areas. It terminates some fibers, goes along. I hope you are able to visualize the previous picture which I showed, a straight picture. Then goes to the thalamus. From the thalamus, it goes to the somatosensory cortex. Is it very clear? Is it very clear? I am talking about this. Imagine the blue, the red, and the black. This is your neospinothalamic tract. It is carried by A delta fibers. It is crisscrossing at the spinal cord level from the dorsal horns, goes towards all along the brainstem, towards the thalamus, and the black one is the third order neurons, which is going towards the somatosensory cortex. Is it very, very clear? Okay. Now, then you have got a paleospinothalamic side. Now, this paleospinothalamic pathway is absolutely for a slow pain. When you talk about slow pain, they are non-myelinated C fibers. Their neurotransmitter is substance P. This is very important. Substance P is a neurotransmitter for slow pain, which is something very important. And this terminates, as I told you, as substantia gelatinosa, which is lamina 2 and lamina 3. Now, again, you will ask me, sir, what is lamina 2 and lamina 3? Lamina 1, lamina 2, lamina 3, all these are various levels of lamina in the dorsal horn of the spinal cord. So now lamina 1 may, neospinothalamic has already got the synapse. Lamina 2 and lamina 3 is called as substantia gelatinosa, and the neurotransmitter is called as substance P. Okay. Now, from here, it goes towards the reticular nuclei of the medulla, the pons. You know, medulla and pons are part of brainstem. The tectal area of the mesenchyme deep to the superior. Now you may understand. You may be in a doubt that what is superior and inferior colliculi. Superior and inferior colliculi are nothing but the two nuclei which are present in the thalamus. So they are in the thalamus, periductal gray area around the aqueduct of Sylvius, and now intralamina. So basically, what do you understand here? Please try to understand here. Now, what you understand here is, please understand that when we talk about two pathways, your neospinothalamic tract, which actually carries fast fibers, A delta fibers, the tertiary neurons are terminating in the somatosensory cortex. The paleospinothalamic tract, which is carrying dull pain, C fibers, which is having a lot of multiple fibers. It is not one neuron to second neuron. It is one neuron with 10 more neurons and going down. Because it is slow, it is terminating in the thalamus and the hypothalamus only. That is something very, very important. So all the pain is not, that is why you have to understand that every pain you cannot localize. Now you understood why do you, now I hope you understand that why are you able to understand that few pain in dental pains you can localize and say I have this pain, and few pain you say that no, I don't know, but I'm having pain all over the jaw, which is a referred pain. So why pain is specific? If the pain is carried by A delta, it is always specific. When the pain is carried by nociception, it is not specific. It is the dull pain. You cannot localize. When you have backache, can you tell one point you have backache? You say that I have a pain in the back. I don't know where it is, but it is a referred pain. My overall back has a pain. So that is where it is a dull pain. It's a slow pain. It's a chronic pain. Acute pain is something where you can point out that I have a pain. Why? Because it exactly goes to the center of your somatosensory cortex. This is what you have to understand. As a dentist or as a exam going student, you have to understand these things. Now, this is something very important. Now, this is something very important. I want you to understand that the pain tracks, we are almost concluding the webinar now, that the pain tracks, as I said you have got two types of pain. You have got fast pain, you have got slow pain. When you have got a fast pain, all of them are traveling. Can you see the base, the stem, where you can see a reticular formation. That means all the pain fibers who are traveling above are giving out terminating some fibers which are reticular formation. They are traveling all along, and you can see that when they are going into the thalamus, the fast pain, if you see there, see very, very clearly, try to see the picture. The fast pain fibers are not ending in the thalamus. Can you see the area there? And then they are going beyond the thalamus, and that is where it is. Can you see the above 3 arrows there? You can see the 3 arrows above there. That is a somatosensory cortex. That means fast pain fibers are relating, or they are relay station. Thalamus is a relay station. It gets relayed at the second order, and the tertiary neuron thalamus goes to the somatosensory cortex. Whereas in case of slow pain fibers, it is ending into thalamus and intralaminar nuclei. So that is a very important difference between fast pain and slow pain. See, this is something very important, and you need to understand. You have to draw a diagram, you have to visualize it, and you can draw in a form of a flow chart where you will very clearly understand the difference between both the pain fibers. And this is what is the exact definition of both the pain fibers, fast pain and slow pain. Okay. So with this we conclude the pain pathways, as today's topic is basically on pain pathways. So we conclude. I am open for a discussion here, and we can have a discussion, and we can see how best I can help you out with that.